Okay, I think we're ready for the next presentation. Thank you very much, my good colleague and friend David Braddock, for inviting me to this very important and needed conference. My topic relates to health promotion and disability, and we'll have our slides up here in a moment. The importance of looking at weight management and obesity is something that I've been very involved in for the last 30 years. And what I'd like to do is share with you, based on some of the work that you've heard earlier today, Bill Coleman making the comment that with today's ability to collect data through wearable clothing and sensors becoming more and more available and less expensive, we might have opportunities now to do what David Braddock and I and several others 30 years ago knew was a problem, and that is that there are substantially higher rates of obesity in people with intellectual disabilities and cognitive disabilities in general, and how can we address this problem? So today, with the technologies that are becoming more and more available, I think we can actually attack this problem much more efficiently and effectively. So my presentation is really two parts. The first part is to sort of give you an overview of some data that we're collecting. It's a longitudinal study addressing various types of health behaviors among a cohort of adults with intellectual disabilities. And the second part of the presentation is a new project that was recently funded that I'd like to share with you in terms of how we're going to use technology to address issues of health promotion in people with intellectual disabilities. So if you get into the data set, you'll realize that all of these profoundly important longitudinal studies addressing how we should change health indicators in the general population like blood cholesterol and blood pressure were created from longitudinal data sets. And that's something that, with the exception of the Pomona study in Europe and National Core Indicators Project, we really have very little data on longitudinal designs that address the assessment or analysis of people with intellectual disabilities across time. So this particular study that you're going to hear about today is really trying to look at how do we begin to track health changes across time in the same cohort. Cross-sectional studies, by the way, which is sort of the opposite of a longitudinal perspective design, are very good because it tells you something is happening in a certain area. And from there, you can begin to ask important research questions. But when we start to get into data sets like the Nurses' Health Study, Framingham, there's a new one that's been funded by the National Institute of Aging called the National Health and Aging Trend Study, NHATS. These are profoundly important studies because they drive the research agenda, and that research agenda comes with funding. So if you don't have good longitudinal data sets that are prospective with the same cohorts tracked over time, it's very difficult to make a case with cross-sectional data. So that's what you're going to hear about today. This is a longitudinal study, and we're hoping to track this for several years to come. We have limited data on actual health behaviors and factors in the environment or elements of the environment, the context of the environment that might make someone with Down syndrome or an intellectual disability actually engage in poor health behaviors or good health behaviors. And today with large data sets, there's a term that you'll hear a lot about called big data. And there are people that are going into biostatistics and other types of statistical modeling programs where they're collecting huge amounts of data. And years ago, before we had the speed of computer systems that we have today, we couldn't really look at converging these data sets. So convergence, a term that Bill used, is also being used in statistical theories and in many of the PhD programs in biostatistics around the country. So we need to get at a better understanding of what are the health behaviors and how are they different or nuanced in different subgroups of people with intellectual disabilities. And intellectual disabilities in and of itself is a profoundly important population for the National Institutes of Health to understand about, because there are very different living environments that people with intellectual disabilities live in, and those are not being explored or examined today. And we found out several years ago, David Braddock and I and several colleagues from the University of Illinois at Chicago, that depending on where you lived, generated or dictated your obesity level or your rates of physical activity behaviors and nutrition. So these are very important indicators that we got to consider looking at in the future. And then third, there's a lack of prospective epidemiological data to drive funding through NIH. NIH is very interested in funding studies that have elements of technology and health and wellness in them. But many of our studies don't make it to prime time. They don't get reviewed because they don't have sophisticated infrastructures of technology that generate the potential for new concepts and ideas. So What is so exciting about the work that the Coleman Institute is doing is that they're trying to use technology for two essential purposes. One is, can we drive down the cost of healthcare in the disability community, and that's people with disabilities in general. And two, it's all about, at the end of the day, what are the elements of quality to your life in a 24-hour period, about 17 to 18 hours of that being wakefulness, that you can consider to be important in terms of wellness and the optimization of life. So this is what this study is all about. The title is LIDS, Longitudinal Health Intellectual Disability Study. The purpose is to advance a similar research agenda so we can play with the big boys. When we go to the federal agencies, we could say, look, you've got Framingham, you've got this new NIA-funded aging trend study, but every study that we reviewed, the exclusion criteria for participating was you had a disability. They don't want people with pre-existing conditions because they don't know what to do with them. They don't know how to develop surveys that people with cognitive disabilities can fill out on a 6-month or a year basis, so they exclude them. They don't understand how to deal with the transportation issues of getting people in to get biomedical data, so they exclude them. So every study that this government has funded, for the most part, has no information on people with intellectual disabilities. So we have to start from ground zero in understanding that, A, are the issues associated with health the same for people with intellectual disabilities as they are in the general population, or B, are there some nuances in the etiology and the environmental situation in many people that may alter what we're predicting in the general population to be either health-enhancing or health-limiting behaviors. So I don't want to go too much into the details of the data because I only have 25 minutes, but this is a paper that we'll hopefully have published soon. It's actually being reviewed now. It got favorable first reviews. We had to make a couple of minor changes, and then it'll be published. So if any of you want to talk more about the details of the study, I would be glad to do that. It had a very sophisticated design. We spent about a year developing this survey, which we tested psychometrically with caregivers of individuals who had intellectual disabilities. We encourage caregivers and community providers to also engage people with intellectual disabilities in completing the survey, and we have data on how many of those surveys were completed by what we call a dyad, the caregiver or the community provider and the adult with the intellectual disabilities, because we feel very strongly, like every one of you in this audience, that the individual, we're talking about the individual's health, that individual should be at the table when we're asking them questions related to certain health parameters. So that's kind of our study design. We sent out 2,841 surveys. We had a very good response rate considering that survey data, you're not getting these kind of response. It was 57%, and then in year 2, we had a return of 81%. So let's get down to the details. Again, I have all the demographics there. It's a cross-section of people with intellectual disabilities. About 25% had Down syndrome. We had 12% with cerebral palsy. Just ID alone was 45.8%. And then also we have employment data. We have actually social participation data, which I can't share with you today in this short time frame. So we've got nice cross-sectional data, and this study is going to continue for the next 5 years. We also have demographics on the level of intellectual disability, the living arrangement, live on their own, with a family member, a host family, supportive living, group home, large congregate facility. And also we received some funding in the first cycle from Special Olympics, so we also had Special Olympics participation to see what the effects of that were. So the top 5 prevalent chronic conditions in adults with intellectual disabilities, this is year 1 is in gold and year 2 in blue. Obesity was ranked number 1. The second condition, and obviously many of you know this, seizure disorders is quite common. Anxiety and depression we were surprised to see as 2 mental health conditions that came up in the top 5. I also have data on 6 to 10. High blood pressure came up, I think, number 7. Constipation came up 8. High cholesterol came up 6. You know, there were a number of issues, but I didn't have enough time and didn't want to put too much on the slide because I think we need to think about this. And thyroid disorder was another one that was of particular interest in terms of the top 5 conditions. Between year 1 and year 2, there wasn't much statistical variation. So that's good. We had good data. It seems like there's some consistencies there. Now, in terms of the chronic conditions, you know, when you start to get out into the purple part of the pie chart, you see that people with intellectual disabilities have a number of chronic health conditions. In year one, 37.9% reported 4 or more of these chronic conditions, and that actually went up in year two to 40.3%. And again, this is the same cohort from year one to year two. So a large number of our participants either had 4 or more, and then the next largest number was 16, or almost the next largest number was 16.8 and 17 with 3 or more conditions. The prevalence of obesity by age and sex, not unusual in terms of what you see here in age groups. The major finding here was, again, this is data from the National Health Institute survey, and we compared our data to the survey. Both of these surveys are self-report, and you can see that the red bar being adults with intellectual disabilities were all higher in each of the age groups. Now, one thing that we need to consider is the impact of these, of what we call a body mass index of greater than 40 or more. And what we found was, I think, to be quite striking, and that is that when we looked at, not as much with the males, but in the female adults with intellectual disabilities, they had about a 2/3 higher rate of morbid obesity. So that's a major issue, because when you actually analyze data on the incidence of obesity and the cost associated with it, you get increases of 10 to 20 times higher in people with morbid obesity, because they have a number of multiple health conditions and are taking multiple medications. So it's something that we need to consider as we move forward. Prevalence of obesity by medication use, not surprisingly, those taking antidepressants and individuals taking 4 or more medications had a significantly higher rate of obesity. So that's another concern related to medications. And what I found to be most striking, I'll have to get through this quickly so I can get through my presentation, is when you tease out the data, you separate the data by people who had a body mass index of greater than 30, so they're classified as obese, versus those who are not obese. 7 of these 10 conditions, this little cross here that you see next to 7 of these conditions, was significantly higher in individuals with obesity. So high blood pressure, high cholesterol, diabetes, thyroid disorder, sleep disorder, depression, and heartburn, acid reflux were all significantly higher in individuals who had a BMI over 30 with intellectual disabilities compared to individuals who were not obese and also had intellectual disabilities. And the other numbers, with the exception of seizure disorders, were actually slightly higher in the obese population but did not reach statistical significance. So finally, when we looked at health risk behaviors, there's a good and bad to this slide. The good is that alcohol and smoking rates are very low, or much lower. This is the Behavioral Risk Factor Surveillance System, which is a national data set published by CDC. But when you looked at physical activity and insufficient fruit and vegetable intake, these numbers were actually higher. We don't know much about them yet because we haven't really dug down or drilled deeper to see what the actual causes of this were. Now, when you look at this by living arrangement, and again, this is just a snapshot, what you see is the circled items are the poor health behaviors. And the two groups that had the highest rate of poor health behaviors, watching too much TV, not eating enough fruits and vegetables, consuming too many fast foods, a little bit higher percentage of alcohol consumption, and oral hygiene being poorer, brushing teeth less than 2 times a day. You could see with the family relative and those living on their own had the highest rates of poor health behaviors out of the group. But again, statistically speaking, we're not sure if this is dramatically different from any of the other living arrangements. It's just something, again, to think about as we move forward. And then I just wanted to throw one more slide before I move into the second part of the presentation, which really addresses obesity in youth with intellectual disabilities. And you can see that in every country, including the U.S., we have significantly higher rates of obesity among youth with intellectual disabilities compared to youth who do not have intellectual disabilities. So this starts early in life, and it's something that continues. So in summary, obesity, as we've known for many, many years, this is nothing new, is a significantly greater health disparity among youths and adults with ID compared to the general population. In certain groups, such as women, individuals with Down syndrome, and adults taking multiple medications, obesity is a substantially greater problem. And the prevalence of morbid obesity, where we really need to focus more of our work, and where NIH would probably be very interested in funding a study addressing this subgroup. We need to focus more in that area. Obesity-related secondary conditions are significantly higher. So as we know, many conditions are associated with obesity, and you can see this is what is happening in this particular cohort. Poor lifestyle behaviors are more common in less restrictive settings in general, okay? So I want to couch that statement because that's something that we have to look at further. And only 1/3 of adults with ID who are overweight or obese were given advice by their health professional on weight management. So there's a very low rate of interaction with the healthcare provider and the DD staff. And with high turnovers, in many of the agencies, as you know, and healthcare providers being too busy, we really do believe that technology might be the answer to now, 30 years later, what we've learned about 30 years ago, we can now begin to address much more systematically with the cloud-based kinds of technologies that are becoming more and more available. So we're very lucky to work with a good colleague of ours, Tamar Heller and David Irvin, who you'll hear about in session 2. We have a subgroup that David is going to present some of his work at the Resource Exchange and how we're going to begin working with one agency to try to address this problem. So this was a study that was just recently funded by the National Institute on Disability and Rehabilitation Research. It's a 5-year study, and we're going to begin to put some technology in place to look at this. Before I begin, I just wanted to throw up a snapshot of, I went out into the literature. This is what PhD students are good at doing. I just asked them to find statistically significant systematic reviews that showed what are the health-related associations with obesity, and they came up with this list. So these were all statistically validated meta-analyses, and you can see that if we have to start somewhere, maybe this is a good place to begin. I'm not saying obesity is the end-all, but when you begin to think of what we're all trying to achieve, which is integration and community participation among people with intellectual disabilities in their community, what better place to start than with health? Build that base, and then from there, begin to think about, do they have adequate housing? Is there some kind of social support system? Do they need a ride to the doctor? Are there issues that come up in the middle of the night that need to be addressed? So the community can really become a unit of analysis with this cloud-based kind of technology that we have available and with this big data concept. We're trying to do this at a very small level. We have very minimal resources in this particular grant to build technology, but we do have 2 new grants that we just received. We received an NIH SBIR, a small business grant, to develop a platform called POWERS, which stands for Personalized Online Weight and Exercise Response System. And in that, we just received from there an NIH-funded R21 to build the system out for youth with spina bifida. So some of the elements of what we learn in those 2 studies we're hoping to use in this new study. But this is not funded yet. We're just hoping that we can get additional resources from the federal agencies to build this out. So the idea would be, it doesn't have to be from a DD service provider. This is just an example. It can come from anyone. It would come to us. We would get this link or this email or this text or this tweet that says, hey, I need someone who really, I'm a healthcare provider, and I live in Colorado Springs, and I'm going to need some help here with this gentleman I just evaluated. Can you give me a call? And then we kind of go through this platform. We talk to the healthcare provider, and then we begin to set realistic nutrition and activity goals based on some baseline data. That goes to a health coach, and we're building a whole cadre of health coaches, believe it or not, in Alabama. But remember, sometimes you talk to people across the world when you make your airline ticket, so don't criticize Alabama. That's a good place to have a technology-based center that's speaking to the entire nation on how we build health promotion. So I have a whole core of PhD students now. I have about 5 or 6 PhD students and several masters who are working on this health coaching strategy. We use techniques like cognitive behavioral therapies, motivational interviewing, but they're learning to speak to people on the phone. And as Bill described earlier, we anticipate someday that there's going to be a flat screen TV, in everyone's home, and the coach and the individual will have a 2-way communication system. So when they wake up in the morning, they'll know precisely what they need to do, and the coach will be there to help motivate them. So it goes from there. We get input from the individual. What do you like to do? What don't you like to do? I really think we failed in the whole fitness industry by getting people to think about how, you just jump on a bike, a stationary bike for 30 minutes a day, and that's going to make you, perfect. Of course, we know that many people go out and buy stationary bikes and they sit in garages. So we've kind of missed the boat here. Exercise really needs to be socially engaging. It needs to be enjoyable. It needs to have some learning component. It needs to be exploratory. It needs to be, in some people, competitive or task completed, household activities or doing chores. That's the way activity was designed when we first began as a civilization. It was hunting and gathering and moving to survive. And we've tried to turn that into building these huge fitness centers, which I'm part of and feel very proud to have a membership, but you can see that many people drop out because it's not reaching the elements of health that they find to be engaging. Now, you talk about the ski slopes. You'd never hear someone, who says, well, I'm going to go out and exercise on a ski slope, and boy, when I hit 30 minutes, I'm going to stop, and get down to the bottom of the hill and say, geez, I got my 30 minutes, I'm not going to do the next hill, I'm going to pass on. Or people who kayak, or mountaineering, or hiking, or biking. They're doing this all day. So we've got to take that concept and that culture and look at the community assets where people are engaged in health and get them to commit to people with intellectual disabilities. So I live in a small town called Homewood, Alabama, and they have this fantastic running club. Not a person with an intellectual disability do you ever see on the front steps of the track shack where they begin their jog who's part of that club. Now, yeah, they're going out and running 5, 10 miles, but they also have groups that do 2 miles. They have some groups that maybe just walk. So what are the community assets that are engaged in health that we can then integrate into the DD service system? And that connection can now be made to a much better extent with some of the technologies that we have available. So here's the kind of the dashboard that we're at. I won't go into the details because of time, but we have all kinds of data that we're now able to collect. And as Siri becomes more available to adults with intellectual disabilities, and as you can talk into systems, that information can be captured through these mobile apps and then uploaded right into the system. So an adult with an intellectual disability doesn't necessarily see this and understand every aspect, but they can get information by either orally expressing themselves or hearing something about the results of their day's activities. And when you get into looking at specific issues, there's also something called wayfinding. So here's a situation where this individual needs to reduce their calories and they've been eating out at these fast food restaurants, but Subway is not so bad. So we've got to find a Subway place. So if they click on Subway, then you could map this out. And again, this is a very rough draft of how this would look, but you could map out where they live, see here, and then what is the closest Subway. And then from there, you can start to use some strategies in your coaching tool to help that person understand that they can walk there from the group home or from where their parents live. You can look at safety, make sure that it's a safe environment. And then with something called wayfinding, which is what you see in this slide, someone can actually click on boxes or maybe speak at some point and say, okay, I want to find an inclusive fitness center. Those pop up, and this is just a symbol that we've used that can change. And it tells you, Eckerd Fitness Center, it gets a score on accessibility. It has a user rating. It has, do they have a certified inclusive fitness professional available? What is the address? And then it even tells you the best time to go. So if you want to go when it's not too crowded and you get more attention, these are the times that you should go. And then you can map this out. So you could say, okay, what is the user type? That would be the first thing, and the person has an intellectual disability. And then it clicks on the actual route that the person takes. And then with wayfinding techniques, which we used years ago when people got lost at sea, a person doesn't even need to read signs. They just need to know different access points in the environment to be able to tell them that when I get to this large building that is this particular color, I'll be able to go this way. And you can start to teach through wayfinding non-verbally how to get access. Finally, I'd like to end with just telling you that I really do think that something I'm missing in my lab is a computational modeling core. And this is very hard to see, but it's what we call an adapted algorithm. And it was done in a project that I was involved with where they were trying to predict someone recovering from stroke, how many sessions would they need in order to recover use of the arm. And so it basically takes you through a series of algorithmic trees and decisions, and based on that, you can come up with predicting through a statistical modeling procedure called Bayesian methodology, which has been around for many years. It's become a really kind of a hot probability sampling tool. You can predict through these decision structures what the potential outcome might be based on their response. So everything related to dosing and rehab can also be related to dosing and health promotion. And this was an article in the New York Times called Big Data. It was Mayor Bloomberg's dream. This is $1 million a year agency called the Office of Policy and Strategic Planning. And they collect everything from the number of rats using geospatial technology, the number of rats in the city to, where are the high crime rates. And what they're doing now, these statistical geeks, is they're actually identifying and resolving problems. So the example they gave in the article was that many of the sewers today are being clogged in New York City with grease, and grease clogs the sewers, and they have thousands of dollars required to fix the sewer and to get it unclogged, and it creates a lot of other problems. And so they were able to get public data to every restaurant in New York is required to have a carting contract to cart away the grease. So they were able to go through that data system, which was hundreds of thousands of restaurants, and identify which particular restaurants were not using that, and then match that up with the geospatial data where they were getting these clogged drains. And in almost instantaneously, they were able to identify the culprits and find them immediately and get the problem corrected. And if that was done a few years ago, they said it would have taken them months, if not years. They would have sent out a commissioner to every restaurant in the areas where they were getting this clogged drain, and they would try to, put people at night with cameras trying to figure out where this was, and they resolved this problem instantaneously. And so they think that in New York City, this is going to be fantastic in terms of understanding where the crime rates are and why there's higher crime or lower crime. They also found, explained in this article, that there was one community where the stores opened later or stayed open later, and the crime rate was substantially lower. So keeping open, instead of closing at 6, they closed at 8, and the crime rate was significantly lower because obviously there were more people out and the stores were open and there was more lighting. So they could look at everything from lighting and heat, transportation methods to really get at this. So I'd like to thank our funding agency, the National Institute on Disability and Rehabilitation Research, through the grant that Tamar Heller has at the University of Illinois at Chicago. Special Olympics also had funding for this. And finally, I'd like to end with, it's just not physical activity nutrition. As we build this technology, we've got to think about that there are really 8 elements of health which we've known through systematic reviews. This was a paper published in the American Psychologist, that it may not be all about this. It could be that we might have to get into more of the relationship building. There's something called technopathologies. Yeah, we could spend too much time in front of a computer, and there's evidence to show that we need to be outdoors more. Nature, recreation has important elements associated with it, religion and spirituality, and also contribution and service. So we need to begin to think about how can we use this health pyramid, and we could change these particular domains of health in and out depending on what that adult with intellectual disabilities need. And also with the kinds of technology that we have today, don't think of this when you leave here as this is a project being generated at the University of Colorado or at Colorado Springs. This is a project for you, because with the technologies we have available today, and with my biostatistician who just came on board recently, we can take models that are successful in what you're doing and integrate them into our system and then build a wiki-like health promotion platform with a state-of-the-art computer modeling center that can get at issues in what we're doing as well as what you're doing. And having that multiple set of data can get us, I think, what we haven't been able to do in 30 years, get us to where we need to be within the next 5 years. So I thank you. I think that health and wellness is the gateway to community integration. And I'd like to leave those of you who really want information, because I know when you go through these presentations, you always say, man, I wish I had more of this and that. We do have a federally funded center called the National Center on Health, Physical Activity, and Disability. It has thousands and thousands of bits of information on intellectual disabilities. David Braddock actually started the center. He was the original PI on this center. It was funded in 1999 when I worked under him at the University of Illinois Chicago, and it is still going today. And so I would like to encourage you to go there. Just put NCPAD into your web browser, and you should come up with something. And I will say that I'm very excited about this new generation, NCPAD 2.0, which will have more interactivity with mobile apps, social networking, Facebook, so that it meets your specific needs. So thank you very much, and I'll be around later if anybody has any questions. Thank you. Yeah.
You can take a question or two while they put the
Oh,
tables
okay.
up. Okay.
Yeah.
We have some tables coming up for the commentaries. So while the tables are coming up, we can have Jim take 1 or 2 questions. So Jeff, if you can help get that going. Great.
Jim or Bill or Kathy, right? Yes. Did you want to? There's a microphone in the middle of the aisle. Yeah. Okay. Oh, it just stands, no microphone? Okay. If you speak loudly, I think I can hear, and then I'll just read.
So I was mentioning, thank you for the very motivational, insightful presentation. And I have a few questions. One is how we overcome some of the issues about economic that goes around this population. So when we talk to them about eating healthier, we know that eating healthier is costly. And then when those places are offering a meal for 99 cents, and then you're going to tell them to go to a place where they have to pay more. So how maybe we can still use the same paradigm? You can still eat for $1, but what can you eat healthy for $1? And second, like when we tell them about going to a fitness center, and my income, annual income, is in the lower end, and then you're asking me to spend $1,000 in a recreational or fitness facility, how we can ask them to exercise without having to be in a more frail situation in terms of their own economic status.
Yeah. Those are great questions, and something that obviously that has been an enormous problem for society in general. How do you get people motivated to eat better, particularly when eating better requires more economic resources? And then the second part of the question was, these fitness facilities are not cheap, and how do you get more of that? So the beauty of what we're trying to build, this scaffolding with these data systems coming in, will kind of lend itself to with geospatial data, where are the fitness centers and what their costs are. And we think that with a little bit of social persuasion, a health center that doesn't have, that doesn't have participants with intellectual disabilities should consider prorated memberships. The Y will do that. And I'm in a fitness center now where there are some people who pay nothing. As long as they are, they can, document their resources, they could come to the fitness center at no charge. Most people want to pay something. So we do need that sliding scale. I also think that we have opportunities now. I hope I'm not speaking ahead of myself, but the Affordable Care Act, has some elements of health promotion built into it. There's a whole chapter. So we've got to argue the point for people with cognitive disabilities, just like they did for aging. There's a woman out of California, Kate Lorig, who developed one of the state-of-the-art evidence-based health promotion projects called Living Well with Arthritis, and that's actually funded through the Affordable Care Act now. You can have a doctor write a prescription, and a patient who's 65 and older can go out and get a whole 12-week program of Living Well with Arthritis. So we are starting to realize that prevention is key. And I really liked Bill Coleman's presentation, because when you start to look at the numbers going up on healthcare expenses, no federal bureaucrat in their right mind is going to not consider elements of health and wellness to get that number down. So, Bill's overarching comment was, with wearable technologies, we can begin to monitor pulse and respiration and temperature, and start to predict, are people more active, less active, what types of foods are they consuming. But finally, to go back to your initial question, we have to change the environment. The environment has to be conducive to everyone, including an adult with a cognitive disability. When you go to Whole Foods, how many people with cognitive disabilities do you see in Whole Foods? 0, right? How many people of low incomes do you see in Whole Foods? 0. So we've got a culture of health, and we've got the answers. When you have enough financial resources, guess what? You could be really, really healthy, right? You can get a personal trainer. You got a state-of-the-art fitness center. You eat the best foods. You can go out and eat where you like and when you want. You've got transportation access, and you've got great health care. You got the best doctor in the world. I grew up in New York. Everybody used to brag about, I got the best doctor. No, you don't. This doctor graduated from so-and-so. But when you get into adults with cognitive disabilities, or people on the lowest end of the social determinants of health, what is so profoundly disappointing is that there's such a difference. And so what is so beautiful about presenting here, because I don't present at conferences like this, I present at conferences that relate to rehabilitation medicine and exercise physiology and fitness, is that this is where we need to be. Because part of the social determinants, part of what Coleman's trying to do is really get people with intellectual disabilities and cognitive integrated into society, but use technology so they don't have to have this overabundance of healthcare management. Let them manage their own healthcare, and with technologies that will be forthcoming in the future, I'm convinced, and I think Bill and others in this room are, that will happen.